Hello, and welcome to NANNcast. I'm Jill, your host. When you hear congenital diaphragmatic hernia, do you immediately think, where do I even start? It's a condition that challenges every corner of neonatal care, from fetal diagnosis and delivery planning to ventilator management, pulmonary hypertension, ECMO, and long-term follow-up. How do we as NICU nurses and APRNs confidently care for infants with CDH when no two cases ever look the same? In today's episode, we're unpacking these nuances and taking a deep dive into one of the most complex and high-risk conditions we see in our units, CDH. From fetal imaging and lung volume predictions to delivery room stabilization to the delicate balance of pulmonary hypertension management, these patients challenge every part of our clinical intuition and push us to think differently about physiology, timing, and teamwork. And to walk us through these challenges, I'm joined with Dr. Jamie Gilley, a neonatal nurse practitioner who brings a wealth of experience and clarity to a topic that often feels overwhelming. In this episode, Jamie helps us unpack the science, the bedside decision-making, and the why behind the strategies we use, from sedation approaches, pulmonary hypertension management, to navigating ECMO decisions, surgical repairs, and what life after the NICU looks like for these families. Whether you're managing post-op care or stabilizing for transport, after you listen, you will feel more confident, more prepared, and more equipped to advocate for the tiniest CDH patients. Let's get right into it. Thank you, Jamie, for joining me today. Let's start with basics. What makes CDH such a significant and ongoing clinical challenge in neonatal care today?
All right. Well, and thank you also, Jill, for having me on. For an NANNcast, this is great. And I think it's awesome what you guys are doing and just getting knowledge, disseminating that globally to multiple audiences. It's fabulous. So one of my biggest passions is over congenital diaphragmatic hernia, or CDH. And this is actually a disorder that's as common as cystic fibrosis. It occurs in one of every 2,500 to 3,000 live births. And unfortunately, it does carry with it about a 25 to 30% mortality in the neonatal period. Most of that is secondary to pulmonary hypertension that we see in this population. So it is something, if you have worked in the NICU for a prolonged period of time, I'm sure you've either seen or taken care of a patient that's been born with CDH. And the management of these patients can be very challenging, not only from a provider standpoint, but also from a bedside standpoint, just because, we have all of these markers and, a lot of the cases are prenatally diagnosed just from imaging studies that have been done. Most of the time, the mom, when she comes in for her anatomy scan, is when they see, oh, the stomach is actually up in the chest instead of down where it needs to be. And so that kind of triggers this whole, we need to get an MRI, referral to a specialist, things along those lines. And, even with the fetal MRI imaging that we have, that kind of looks at, the total fetal lung volume, which measures the lung volume in the baby kind of compared to what it should be, to what it's showing. It also looks at the percentage of the liver that's herniated up in the chest. And most of the time, the type of CDH that's diagnosed as a left CDH, the left Buckle duct type is the most common, but obviously it can occur on the right, on the left, in the middle. And so we use these markers such as the total fetal lung volume, the liver herniation rate, which all of these are noted on an MRI. And then we also look at the lung to head ratio, and that's essentially calculated by looking at the dividing the fetal lung area by the fetal head circumference. And that number kind of gives us an idea of, I don't want to say outcomes, right? Because we have some of these babies that come out and they have really great markers and they end up being super, super sick. And so it's, the management at the bedside is very similar to all babies, despite whatever their prenatal markers are. And so, and then the other thing I think that's really important to note is that if you have a baby that has a right-sided defect or a middle defect, or all of these numbers are based off of left-sided studies, right? So when you have a right-sided defect that has these crazy numbers, obviously we look at them and they're important for us to know, but from an outcome standpoint, most of our data is based off of left-sided numbers. So I do think though, the more we see and treat babies that have CDH, we are getting to know a lot more about it. One of the other things that I think that has come in the last, decade plus is the prenatal intervention of the feto or the fetoscopic endoluminal tracheal occlusion, which in babies that have severe left CDH, they basically put, when they notice that the baby has on the scan that they have the diaphragmatic hernia, if they qualify for it, because it's still a clinical trial in the United States, they actually put in this little balloon in the airway in the trachea and inflate it with the hopes of allowing that amniotic fluid and that lung to grow on that side. And then it is an invasive procedure, so they do have to go in and physically pop the balloon before delivery. And the moms that have this procedure done have to be very close to a facility that's able to, manage that balloon if the baby were to deliver, before their due date or before they're able to take the balloon out. Really cool though, in Europe, this is something that they're doing over there that it has not been FDA approved in the United States, but they actually have a fetal balloon that has a magnet in it. And so they place the balloon, and then when it's time for the balloon to be popped, they actually have the mom walk around an MRI scanner because it's a giant magnet and it pops the balloon. And so it's a less invasive procedure. The mom doesn't have to undergo while baby's still in utero. And, it's just something real quick that they can do. They have her walk around and then they do imaging and then they notice that the balloons pop just based on where that magnet's located. So lots of cool, innovative studies are coming out. But, like I said, despite all of these things, just the prevalence and the mortality rate really, unfortunately, hasn't changed despite all of these things. So
That's amazing. I mean, that feto study can really change the landscape of how we treat CDH prenatally and then the outcomes that we're going to see after delivery. So more exciting things to come.
yes, absolutely. It's interesting, we talk about how most of the time CDH is prenatally diagnosed, but there are some instances where, you go to a delivery and you're like, something's going on with this baby. And you're looking at them breathing and, they've got that kind of concave or sunken in abdomen and you're listening and you don't really hear good breath sounds on one side. And then you get your x-ray and you're like, oh my goodness, there's bowel in the chest. And
Surprise!
I know. Oh, so it's one of those things that, you have these clinical signs that you're looking at. And then, of course, when you notice it, sometimes these babies have already gotten PPV. So they've got air that's now traveled post the stomach and it's all in their intestines. I will say, though, the babies that are later diagnosed, so they're not picked up on that initial anatomy scan, most of the time, those babies have a later herniation where they tend to be not as severe. So, we rate our severity based on a type A, B, C, or D. And a type D is the worst defect, meaning that there's little or no diaphragm present. So they typically require a patch placement. Whereas A is a more mild defect. So sometimes a type A or B can be a smaller defect. Sometimes they're contained within a hernia sac where you just go in and kind of, push the bowel back down. And sometimes these patients actually have enough native diaphragm where you're not having to sew in that patch or that artificial diaphragm, if you will. So, it's interesting to see, these that are diagnosed a little bit later, they tend to statistically do a little bit better typically because the defect is a little bit smaller in size. So, but delivery room management and resuscitation for these patients for a prenatally known is, kind of standard. And I'm sure for those who've gone to deliveries, I'm sure your institution kind of has, guidelines in place where, you don't give that PPV, you intubate, you put that Repulgol into the tummy to suck all the air out. Many times they need a PIV or lines to be placed just to make sure we're giving, because they're not going to be able to eat. So you have to be able to give nutrition. Our institution, and I'm sure there's a lot of institutions just kind of looking at global databases on CDH management. Most of the time, these babies require sedation just because you want to be able to kind of help them with their oxygenation and ventilation once they're intubated. And so every institution uses something a little bit different. But, sedation is kind of a big thing. And then I remember, 15, 20 years ago, we would give vecuronium to a lot of these patients. That was just kind of the standard. And then, they came out with, research saying, these patients really should breathe on their own if they can. Giving them vecuronium actually can worsen outcomes, is what kind of the statistics showed. So I know we do utilize it in severe cases still, obviously. But if you have a patient that's doing pretty well, is on sedation, the goal is to kind of let them drive their own ventilation and not take it away from them, and avoid vecuronium. But once again, sometimes in those severe cases, it may need to be utilized. So, and the other thing that I kind of wanted to mention here, and I'm not sure, Jill, if you've seen this, I'm sure other people maybe have seen this in their practice, but when you try to place umbilical lines in these patients, not so much the UAC. I feel like most UACs typically kind of go where they're supposed to, but we, in my own practice, we've noticed our UVCs, just because if the liver's up, you have no idea where the ductus venosus is, if it's even open, where is the line going? And, there's been instances where we'll get chest x-rays and we're like, that line looks like it's in really good placement. And then, you get an ultrasound and they're like, oh, your line's in the liver. And you're like, oh, man. So, after looking at this data, and I was very thankful to Nan, who actually published our research on this, but, we noticed a high malposition of UVC. So we actually transitioned over to doing a low-lying UVC until we can get a PICC line or a more central line put in place. And it actually helped to eliminate the negative side effects you see if your line is malpositioned, because there was a great study that was done probably 3 or 4 years ago now that actually looked at UVC malposition in the CDH population specifically, and just found that a lot of times these lines were malpositioned. You would get pericardial effusions, liver hematomas, extravasation of fluids. And so there is actually some really good literature to support, really making sure if you're going to use a UVC, ultrasounding and making sure it's in good placement, or, you can adopt another method of either doing like a low lying or maybe just putting in a PIV and placing a PICC, whatever works best for your institution. But just knowing that those UVCs can be very deceiving on chest x-ray with where they're placed. So, and then I think it's also interesting to kind of look at, the different schools of thought on ventilation, right? And, management postnatally with these patients, because, conventional ventilation is kind of, standard, what we will utilize kind of like a cyst control volume guarantee method to let the baby kind of drive. But then if they're needing higher pressures, which sometimes these babies do, what is your next step? Do you keep them on conventional? And, you don't necessarily want to give more pressure because you could injure that good lung, while you still have all this stuff that's pushing on the maldeveloped lung. And so there was a study that was actually done over oscillator versus jet ventilator usage. And I know a lot of institutions will utilize the oscillator either as an initial therapy or a rescue therapy. And, it's a more gentle ventilation on the lungs, then it's proposed to be a more gentle ventilation on the lungs. But, if you use a nice volume guarantee mode, I think that's also gentle as long as you're not using these super high pressures and high peeps. And, once again, I think it's really interesting just kind of looking globally at what other places are doing. But in Europe, they actually have a clinical trial right now that's going on where babies that have less severe defects, because right now our standard of practice is to every baby with a prenatal CDH diagnosis gets a breathing tube placed in the delivery room, right? Even if they're concerned to have a type A or a type D, which those defects are categorized during the surgical repair. But based on their prenatal markers, you can, somewhat get an idea of, oh, this is a large defect versus this is a smaller defect. But it's interesting because in Europe, on the babies that have the smaller, like they have a pretty decent amount of lung volume, maybe not a lot of liver herniated, they're actually trialing some of these patients on CPAP. And so they're doing a CPAP trial over there for those that have the less severe markers. So it'll be very interesting to see when their data comes out, once they publish that in a couple of years, kind of what their outcomes look like for these less severe, and do all of our patients need to be, intubated. So I know it kind of makes some of us a little bit nervous to think of not having like a breathing tube in, but it is interesting. And once again, I love all the research that's going on from a global standpoint, and just looking at all the different areas and avenues of ways to manage, our patients with CDH. So there'll be some more to come from that.
I think that's what's so challenging and frustrating as providers and bedside nurses is there's so many ways to approach it. And, you said sometimes we can use high frequency ventilation, sometimes we use volume. and now CPAP.
Mhm.
And it's, and we know what we need to do, but it's
Mhm.
difficult to find out what's best for the babies. Like, there's a lot of controversy on blood pressure management
Mhm.
for these
Yes.
babies. So what's your take on blood pressure management? Because I know that there's babies with CDH have left ventricular dysfunction, so
Mhm.
people approach that differently. So what's the current status on blood pressure management?
Yeah, and that's a great question because I feel like this is an ongoing debate and this sparks so many, it's like it's a hot topic every, CDH conference I go to, they're talking about different pressures that that you utilize. And dopamine was like the standard, 15, 20 years ago, dopamine was like everybody got dopamine. But
Uh-huh.
then now there's all these animal studies that show dopamine and pulmonary hypertension are not good. It can actually, in the animal studies, it shows it could potentially make, worsen your pH, if you will. And so I feel like epi is kind of that initial drug of choice, right? It kind of helps overall globally. And then if you have a left-sided heart that's not happy, or even the right side of your heart, it tends to be a better medication to use. And then the secondary medication, I know that there's lots of ongoing discussions regarding vasopressin, which I think works great, but it is an antidiuretic hormone. So if you have a baby that you're trying to not have a lot of fluid or have a lot of fluid retention, and then you put them on vasopressin, that's going to cause them, to potentially not have a lot of urine output. You can, you just kind of have to be mindful. And then, of course, the other drug that people talk about is norepinephrine as well as a drip. I think it's also very interesting because once again, I can remember when we used to give Decadron, to these babies, once again, 15, 20 years ago. But now, there's not a lot of data on this, and it's something that I think would be very interesting to study and to look into. But, adrenal insufficiency in this population, right? And I know we have a standard that, if you're needing to start any kind of vasopressor support and escalate it, adding a little bit of background hydrocortisone on board just to kind of help, with that blood pressure management, kind of not really knowing if these patients are adrenally insufficient or not. And I did actually a couple years ago look into some outcomes regarding babies who got hydrocortisone at an earlier time period, and just it was a very, very small sample size, but in a 24-hour period, the babies who first got hydrocortisone within that 24-hour period, their vasoactive indicator scores, or the scores, if you're on drips, there's a scoring system you can utilize that if you're really high on certain drips, it'll give you a certain vasoactive indicator score. For those babies that were started on hydrocortisone within that first 24 hours, they actually had lower BIS scores. Now, very, very small sample size, more research definitely needs to be done, but it's still a very interesting concept, right? Like starting a little bit of background steroid on these patients could potentially be beneficial. Um, you know, but once again, we need more data. And I love that you touched on the left ventricular heart dysfunction, because I think this is something, once again, that in the last, several years, it has become more and more apparent. There's a group out of Scotland, actually, Dr. Neil Patel's group, that has done a lot of research on left-sided heart dysfunction in this patient population. And essentially, they do echoes very, very, Dr. Patel actually does them, very, very soon after they're born. And he found that a lot of these patients actually had LV dysfunction. So when you're talking about that, and I know nitric was, there's some discussion now regarding the utility and the benefit of using nitric, but if you have a patient that has LV dysfunction, obviously nitric is not really going to be your friend. So there was, several studies that have been done looking at nitric in this population, and there's a lot of really mixed literature regarding the benefit of using it versus not. So obviously it's still utilized, right? Because we know pulmonary hypertension is a really, really big, it's a really big issue in this patient population, very much so.
I want to talk about pulmonary hypertension, but first, I do know a lot of institutions use milrinone
Yes.
for left ventricular dysfunction. So, what are your thoughts on that, and what does the literature say about the use of milrinone?
Yeah, so I think, milrinone is great if you have LV dysfunction, but the other thing with milrinone is it's going to globally lower your overall systemic blood pressure because of the mechanism of action that it has. And so if you have a patient that you're already kind of, on multiple pressors trying to get that blood pressure up, that they have a little bit of LV dysfunction, and we do know that you need you need a good blood pressure to have good pulmonary blood flow, and especially babies with pulmonary hypertension, arguably they maybe even need a higher, blood pressure in order to overcome that vascular resistance. And so I think, there's a utility for it in this population. I do think you have to be very cautious if you already are having issues with hypotension, knowing that if you start running into issues with worsening hypotension, worsening acidosis, rising lactate, that could kind of trigger you down into, lower pH crisis, and then you start going down that ECMO route, if you will. So once again, I think it's definitely something that can be utilized, but it's one of those things that, every medicine you give has a potential to cause another issue. So if you have a great blood pressure, I think it's fabulous. But if you're kind of teetering, you would just have to be really cautious with starting it and making sure you're able to maintain that blood pressure status.
So we keep mentioning pulmonary hypertension.
Yes.
So we all know that pulmonary hypertension is probably one of the most challenging aspects of CDH.
Mm-hmm.
It's kind of a balancing act, I feel. What strategies are used to reduce pulmonary pressures, both pharmacological and nurse-driven, non-pharmacological?
When I think of CDH, I mean, CDH and pulmonary hypertension are they're synonymous. And there's a lot of conversations ongoing, regarding, there's different types of CDH. You have maladaptive, which is, where you're born, and, maybe shifting over to postnatal life. You have maldeveloped, which I think a lot of people, the school of thought is that inherently patients with severe cases of CDH, those that have really bad pulmonary hypertension, and, you see it right after they're born, right? Like these are patients that you're having issues oxygenating and ventilating, and the blood pressures are low, and, their oxygenation index is super high. And, these are the patients that go on ECMO because of their pulmonary hypertension. And so inherently are these babies born with some type of vascular abnormality at the pulmonary artery level that's causing this pulmonary hypertension, versus just a maldeveloped, because all babies when they're in mom have their pulmonary vasculature is high. We have to give it that time to, relax after birth. But I think that this is so important because I think this is probably one of the biggest things that as providers and bedside nurses, it's the biggest challenge that we see at the bedside, right? Because these are patients that you are hands-on from the moment that they're born. You're putting a breathing tube in the delivery room. You're putting, that Repulgal in. You're getting lines in. They're going to the NICU. They're getting x-rays done. They're constantly being touched, constantly being manipulated to make sure that everything is where it needs to be. You're adjusting ventilator modalities. And so I think sedation plays a really big role in this, making sure you have really good sedation on board. And I think as bedside nurses, one of my biggest things that I always ask is, do you think this baby is adequately sedated? And I will say the majority of our nurses, when they know a baby with CDH is coming over, they have their PRNs drawn up. We've got the drips pre-ordered and ready to go, because we know sedation helps these babies. We know that it helps to prevent them from going into a pH crisis with all of these interventions that we're trying to do. So I think sedation is really important. And I think also trying to find a way to minimize stimulation, which once again, I think is so incredibly difficult in this population in the first, 4, 5, 6 hours, because that's typically when they're the most acute, right? When they're transitioning, you're kind of tenuous. Are they got a honeymoon, or are we looking at, going on ECMO? And so I think, bedside nurses play a huge, huge role in all of this with, really advocating and saying, hey, we need to stop. I need to give this sedation. If we can wait a couple minutes for this x-ray, let's do that. Or, hey, I just gave my bolus, let's wait and see. Because, I feel like a lot of stuff that's going on. And, making sure that you have a patient that's adequately sedated, that's at risk of a pH crisis is paramount in this situation. So, and then I think the other thing too, just from a provider and a bedside standpoint, is we talk about trying to figure out the timing of an echo, right? Because I know everyone wants to know what's the heart doing in these patients, right? And echoes, even dedicated echoes, that's a probe that you're putting on the chest on a baby that's trying to breathe, that just, has high PVR as it is. And so I think that, trying to determine that optimal timing, and I know a lot of times we'll look at, was there a prenatal echo that was done? Was the anatomy appropriate? But I think, whatever interventions or procedures are being done, making sure that we're giving that good sedation beforehand to make sure the patient is very comfortable. So that would probably be my biggest minimizing stimulation and sedation are going to be, and then optimizing your blood pressure, optimizing your ventilation and oxygenation as much as you can. Those are going to be the key things to keeping the patient in a nice, steady, non-ECMO state, if you will.
Yeah, I feel like the nurses often act as like gatekeepers in the room,
Yes.
like lights out, be quiet. Like,
Yes.
why do you need to come in here? And like, those are the ones that really thrive, and they do much better when they have that
Yes.
strict nurse keeping on top of everybody.
Absolutely. And I love that. Like I love, because there's a lot of people that are involved in the management of these
Hmm.
patients. You've got, the surgical team, the neonatology team, potentially pulmonary hypertension. If you're worried about this patient going on ECMO, you may have, ECLS. You've got a lot of people and a lot of hands coming in. And so I think just having that gatekeeper to say, hey, like, is this really necessary right now? It's so important. Like it's, trying to minimize as much stimulation as we can, especially in the first 24, 48 hours of life. Because that to me, we all hear of the honeymoon stage, and I feel like some of them honeymoon really well. And then, we typically see it after that 24-hour. But then there are some of them that have no honeymoon at all. They come over and you're like, yeah, this isn't going well.
Yeah,
So,
and it's hard too because the nurse also has to be able to educate parents and family
yes,
that want to visit, and of
of
course it's their
course.
baby. They want to
I
try to
know.
bond. So it's at that balancing act of letting the parents bond, interact with their baby, but to an extent where we're not oversedating. So that's a lot of pressure on
Yes,
the
it's a
nurse
lot.
to do that. But they make it work. So.
They do. And I think one of the other things, just talking about, interventions that we can do at the bedside, especially with bonding, because I think bonding is so important. And it's always sad because you want every family and every mother to be able to hold her newborn baby. I mean, and we see with babies that are really, really sick in the NICU, not just with diaphragmatic hernia, but with other, disorders, that sometimes these moms will go days, weeks without being able to hold their baby just because of how sick they are. And so I know one of the things that I think is really great, especially for moms who are wanting to breastfeed and stuff, is we do little like loveys where like, you can put the lovey like a little hard cloth, or if the mom has, like a hat or something like that, you can put in the bed with the baby and then give it to the mom. So that way she has the baby smell. So I think that there are wonderful nursing interventions that are done and that, really can kind of help with that baby bonding, but it's still challenging and it's still very difficult, especially when your patient is so acute and so sick.
So let's talk about big decisions,
Mhm.
ECMO and surgical repair. So, what are some early indicators that a baby might need ECMO?
Yeah, so one of the things that, from a prenatal standpoint on the MRI, some people will say that some of your markers may be a good indicator, like your total fetal lung volume. Once again, the research that's out there is we've had babies that have really good indicators, once again, that end up going on ECMO. So it's kind of hard to tell just based on that. And so I always operate under the assumption that every CDH patient will potentially need ECMO. And I think that's kind of the strategy that many of my colleagues have also adopted. But postnatally, you can kind of get an idea. You're having difficulties oxygenating and ventilating, so your oxygenation index is going up and up and up. And for us, our parameters are if you're consistently having an OI of 40, like over 40, you probably need to start having that conversation about ECMO. That's kind of one of our boxes that you check that yes, if your OI is 40 or greater on, two measurements, you really need to start thinking, best interest of the patient, especially if they've got a lot of stuff in the chest, because essentially you're not trying to get that lung to expand and to oxygenate and ventilate appropriately is not going to happen until babies are repaired, right? Because you've got so much stuff in the chest, and especially if it's a right side, because you have the liver, which the intestines and stuff I think of as kind of smushy. I don't know if that's the right word, but your liver, your liver is more dense, right? So it's like it's a little bit harder on that right side because you're dealing with the liver versus the intestines. But your OI, I think, is a good parameter. And then also your lactate. Because if your lactate goes from 1 and then it's 5 and then it's 8, obviously, good oxygen is not getting to the tissues, and you've got things going on at that level that you need to address. And so just trying to optimize everything. And so those are some kind of indicators. And then, there's always a big discussion of VA versus VD. VA, if you've got any kind of cardiac involvement, and, once again, this is a big discussion that takes place with neonatology surgery. I mean, there's lots of people that are trying to weigh the pros and cons, right? Because, VA, you're actually utilizing a carotid, right? So that's a carotid artery that once you utilize is not going to be viable afterwards, right? Because that's where the cannula goes. And so, it's not to be taken lightly, the type of ECMO that you choose to go on, but, a lot of our CDH patients, high percentage of them, I would say, have some type of either cardiac dysfunction or pulmonary hypertension. And so, I would say at least varies by institution, but VA, and if you can use VV, that's great. But, I think you just kind of have to weigh the pros and cons of like what's going on with your heart at the time. And then, of course, there's always a big conversation of timing of repair, right? Because some institutions will repair right after going on ECMO. You already have that inflammatory response, like letting that calm down and then doing a surgery that's going to send the kid into another inflammatory response. Some argue it's better just to try to do everything once the kid's settled on ECMO. Some people wait. Once again, Europe, I've heard of institutions that will keep kids on ECMO until their pH is better, or until they're not concerned about pulmonary hypertension as much, and then they'll repair. So there's just so many different schools of thought on the timing of repair. And I really think it's institution-based, an early versus a late repair, and surgeon-based once again. So, and then of course, the likelihood of who's going to need a patch versus not. I think, we have these prenatal indicators once again, and then but really the determination of the type of defect, whether it's an A, B, C, or D, and then also the need for patch placement will occur whenever they actually go in and do the surgery. So, and then that's a surgeon preference as well, kind of based on how much diaphragm is there. If they have a lot versus little to none, they'll kind of, base their defect type based on that diaphragm.
So surviving CDH, going through surgery, ECMO, all of the challenges with that in the NICU is just the beginning. So after they survive that, they leave our NICU doors. We don't always know what it looks like to be a CDH patient outside of the NICU, but we all know that they have a really long road ahead. What does discharge planning typically look like for these babies? And what are some common supports that they're going to require when they go home?
Yeah, so I think one of the things that, as providers, we focus on this acute critical management and getting them to that discharge point. And, I think one of the biggest things that families tackle, either if patient goes home on oxygen, whether it's a cannula or a tracheostomy, weaning that off as an outpatient, making sure they have that adequate pulmonary follow-up. But I think one of the other big things that parents, I think, struggle with a lot with these patients is feeding difficulties and failure to thrive and growth, because we have to limit the amount of fluid we give, right? Because we can't give a bunch of fluid because of the lungs. So many times these babies go home on these, high calorie feedings with, lower volumes to just kind of help support their overall growth. And I think what's really interesting is, every institution once again varies, but, you may be working on oral feedings, but go home with an NG tube. Some people have different schools of thought about sending home right away with the G tube, especially in babies that have a bigger defect, just because they're at higher risk of reherniation. So when they go in for their surgical follow-up, whether it's at 3, 6 months, 12 months, when they have that really big linear growth, if there's any kind of reherniation, or they need to refix the patch or something, or redo the patch, if you will. But some people will send babies home with G tubes as well. It's just, once again, I think it's very institutional based and surgeon preference, if you will. But I think one of the big things that we don't talk about is potential for dysphagia in this population. And I actually, myself, along with some colleagues, just did a study. And once again, we need more patients. It's a very small sample size, but it was very interesting to see the amount of patients, because we looked on the outpatient standpoint as well. It wasn't just inpatient. We kind of looked at how the patients were doing. Did they go home with an NG tube? Were they all PO feeds? And then seeing from an outpatient standpoint, how many of these patients needed swallow studies, how many of them had silent aspiration, how many had dysphagia, and, risk of rehospitalization due to, potential complications from that. And so I think feeding is a really, really big thing that, we know that it's an issue and that as an outpatient, failure to thrive and feeding difficulties are a big thing. But I think that there's a lot of things we can do from an inpatient standpoint to kind of prepare these patients, such as getting our occupational therapists involved, if needed, speech therapy, making sure that they have all of these follow-ups whenever they go home, just in case they run into any issues, they're kind of already plugged into a system to where they can get those needed therapies. And then I think also some of them may need GI or nutrition just because they need such high calories in order to grow and to achieve that, that growth that they need to be hitting those milestones. And so, there's once again lots of talks about really kind of having some type of follow-up longitudinally for these patients. And once again, Europe talks about this at their conferences as well, like trying to have a central program in place. And I know some institutions actually have CDH outcomes clinics, which I think are great because they typically combine your pulmonary hypertension or pulmonary team and then also surgery. And you see these same people at, 6, 12, 2 years of life, and kind of helps you keep track of how they're doing from that longitudinal standpoint. Are they hitting those milestones? But it was kind of eye-opening, I think, to several of us when we looked at this study with dysphagia and then kind of looking at, there's lots of animal models that show esophageal dysmotility and stomach dysmotility in babies that are born with CDH just because of how their anatomy develops. And so once again, more studies need to be done, but it's very interesting because if we're seeing this in a large percentage of patients, having those questions of should we be doing swallow studies before they go home? Are we noticing this in more types of patients, like our CD babies are having, higher risk for aspiration and dysphagia versus the, patients that maybe didn't have a patch in place. So I think it's just very interesting. And I'm hoping that research will continue and we'll continue to get more information because like you said, it's a lot when babies go home. I mean, it's not like they just go home and there's still a lot of difficulties that they face and challenges that families face once they're discharged. And, I think feeding, speech, growth, things like that are all things that we try to focus on in the acute period, but like long-term wise, there are things that the families are still having to address and are needing to see multiple specialists for as an outpatient.
So looking ahead, what's on the horizon as far as treating, management, research, and innovation for CDH?
Yeah. So, once again, CDH research, I think it's phenomenal. And there's so many new studies and new things popping up, whether it's here in the United States or, over in Europe. And I know one of the things that's kind of been discussed and talked a lot about, and I think that there is either a study that's about to start or one that may be ongoing. But, we've been doing delayed cord clamping in our, preterm babies and term babies as long as they tolerate it. And there's been a lot of benefits that have been associated with delayed cord clamping in the neonatal population. And so there have kind of been, it's kind of a buzz, if you will, of, in our CDH patients, could this potentially be beneficial, right? But obviously being mindful of the fact that, we don't want them breathing in and swallowing a bunch of air because their intestines are in their chest. And so like, how long do you do the delayed cord clamping for? And, do you wait the full 60, seconds versus 30 or whatnot? And then kind of looking globally at the benefit of, doing this, and will it help with anemia? Will it help with hypotension because they have more blood volume with the delayed cord clamping? So I think this is a really interesting study. And I think I'm going to be optimistic that maybe it will prove to be beneficial for those babies that tolerate it. But I think it's definitely something to look into because we've seen benefits of it being done with our neonatal population. So, and then I also know I spoke earlier about the FIDO. So it's still it's an ongoing study in the United States. It still has not achieved FDA approval, so they're still actively enrolling for that. But I had told you, like in Europe, they kind of invented this balloon. It's actually been approved in Europe, and they're kind of looking at this balloon that has the magnet in it that pops when you walk around the MRI scanner, which I think is just so cool. So more to come with that. Once again, talking about prenatal markers and really not knowing severity. I know that there are, people who are looking into, is there a possible biomarker out there? I don't know what that biomarker is. I don't know what it looks like, but is there some type of biomarker that, that will kind of give us an idea of patients that will come out and have more severe pulmonary hypertension? So I know that there are people who are looking into that and, trying to kind of narrow down. Part of my PhD dissertation work was actually looking at like endothelial to mesenchymal transition on the arterial level of the pulmonary arteries. And is that potentially causing, the pulmonary arteries to have that, lead pipe around them, essentially, is what my mentor would call it. And they don't dilate appropriately. And so looking into things along those lines, like if there's something specifically that could potentially tell us how severe pH will be. But once again, to date, there is no specific biomarker. I mean, there's lots of investigations ongoing. So I hope that someone finds something somewhere, because it would be nice, because, like I said, we treat all babies born with CDH essentially are treated the same, because we have no idea of how severe their pH will be. So we can't really tailor these bedside care plans to individual patients, because we have no way of really knowing how sick they're going to be. So, and then I know earlier we talked a little bit about nitric oxide and its usage. And, there's lots of different literature out there. And there's something called the NONO trial, which is inhaled nitric oxide and CDH. So an interesting study as well, looking at outcomes and utilizing nitric oxide in this patient population. And then once again, I feel like there's also just ongoing research looking at the different ventilation modalities, specifically from a high frequency standpoint, the oscillator versus jet ventilation, especially as we utilize the jet ventilator in a lot of our premature babies, and from an obstructive airway component, it works really well. And so, but the studies in the CDH population, we're still needing, more research and more data to kind of figure out which, if any, high frequency, modality is really beneficial. Because I know that a while back, they looked at conventional versus high frequency ventilation, and they found the outcomes were similar in both groups. But once again, they're different ventilator modes. And, the oscillator, if you have like an air leak or something along those lines, tends to be a lot, gentler than conventional modalities. So it will be interesting to see what that research shows as more data becomes available. So
exciting things to come. I think there's always controversial discussions about CDH management and care. So hopefully some of these studies will help solidify our treatment and help kind of end these conversations that we're always having at the bedside when caring for our CDH patients. So thank you, Jamie, so much for walking us through the complexities of CDH, from the prenatal diagnosis to nursing care to way beyond discharge. So hopefully everybody will be able to feel more comfortable when caring for these babies and be excited about all the future has to hold for our CDH baby. So thank you. Make sure you never miss an episode of NANNcast by subscribing now. This podcast is made possible by listeners like you. Thanks for your support and letting us into your ears. Have a great day.